That's a great question. I think what I hear most is what the core issues are, and the core issue for us is providing access and affordable health coverage. And the reason we need affordable health coverage is not necessarily for anything other than focusing on providing access to healthcare services at the right place and the right time. I think you guys are not alone in the struggle with how to handle the individual mandate, how to handle the IRS requirements, how to do the right reporting, and really how to calculate what your future health insurance budget is going to look like. You're not alone in that. That's going on all over the state. It's a difficult thing to do, and it's everybody is looking at that. So what the biggest misconceptions are, I'm not sure I can answer that. I think most importantly, you all are struggling with how you can provide access to health services for your employees. And we want to be there to help you do that and figure it out with you.
I think there are some misconceptions out there about the intent of health insurance exchanges or changes to the health care insurance policies around insurance. There are some who wonder, will there be severe penalties associated with not having coverage, or required to have coverage, et cetera. But I think one of the other misconceptions is that there's this impending economic collapse of this system entirely that basically makes it go away. And for us, at least here in Vidant Health, working with the NCHA and others, the strategies that we deploy and that we're working through today are those that we know will take us into the future state that meets the industry needs. It will be a challenge, certainly, but we're focused on making the health care more affordable, reducing the costs, and at the end of the day, is the entire thing a collapse because it's bad? No, there's a real need for reform. When we look at the affordability of health insurance, the affordability of our health care coverage, even the industry structure of how we're put together today, we're hospitals built to rescue sick patients. That's not really built to cure disease or prevent disease from a hospital perspective. So we know by partnering with physicians and partnering with other providers and the community, education systems, healthcare systems, as well as public health systems, that we can build an industry structure that will meet the challenges ahead and sustain itself through those times of change.
All right, our next question for the panel is, how will the Patient Protection and Affordable Care Act affect companies with less than 50 employees?
Today, when you look at companies with less than 50 employees, there's about 57% or so that actually provide insurance coverage. So we know that there's a real need then to increase the availability of health insurance for those groups. So the Health Care Affordability Act creates a little bit more opportunities for small business owners to provide health insurance by making it more affordable and creating a new access marketplace for them in health insurance. These health insurance exchanges, for instance, bring together a health insurance plan in a competitive fashion to lower the cost of those plans, and then spread the plans over not a small number, as would be the case for any small employer, but over a larger number, as would be the case with a co-op or a group of those insurance plans working together. So beginning in 2014, these health insurance exchanges are made available to small businesses with less than 50 employees. There's also tax credits associated with that. For small businesses who have less than 50 employees, and I believe that it is $50,000 average wage of those employees. Give me a smaller microphone that works better. Like that. So with those small businesses that have less than 50 employees and have average wage index less than 50,000, there's this ability to use the health insurance exchange to lower the cost of insurance for them, and there's also tax incentives, tax credits associated with that. So there is a tax incentive of 35% for those less than 50 on the cost associated with insuring their employee base.
All right, and that was going to lead to my next question, is about small businesses that provide qualified coverage for employees and the tax credits that are available under the law. Can you describe that to us in a little more detail and how that may affect businesses?
Well, when the health insurance exchanges are established, and for the state of North Carolina, that is now going to be federally driven as a default for us. But what they do is bring together a much lower cost. So for small business owners, there's just an absolutely lower premium associated with that. The tax credits themselves are 35% of the dollars associated with the cost of those premiums. And for qualification, there's also the requirement that the insurance company itself, the insurance exchange that they have, has 80% of the money going specifically toward medical cost, not the administrative costs. And under those scenarios, insurers, small business insurers, get a higher quality insurance product, more focused on the actual medical care components, preventative care and that sort of thing, with those tax credits, making it much more affordable than it is today. Not to mention the fact that if you're a small business owner of 10 employees, those premiums spread across 10 employees are very high. With a co-op, those premiums are spread across many small business owners participating in the exchange.
Yeah, I think essentially it comes down to average wage and size of your company, and as your company gets larger and wages go up, the cost sharing with the federal government will decrease. I think the health insurance marketplace will be a great opportunity for you all to find new and innovative ways to pay for health coverage. That's the intent, and that's the hope of these marketplaces is, like Brian said, spread the risk amongst a much larger pool. And we hope it turns out that way, but that remains to be seen.
The next question is, what implications will the law have for healthcare providers, including hospitals, Brian, and doctors, individual practices?
So that's a big question with a lot of answers. And I will start to say, because we want to have an education discussion today, I'd be remiss if I didn't point out other people that I can deflect questions to as well that are here today. Dr. Cunningham, the Dean of the Medical School, is here today. He is eager to answer a lot of these questions, I'm sure. And Steve Lawler, the president of Vidant Medical Center, my boss, is here today. Oddly enough, the person originally asked to do the panel who was out of town today.
Worked really well.
So, but he also serves as the past president of North Carolina Hospital Association and on regional policy boards for the American Hospital Association. So there's a great deal of insight into the government components of this. But for hospitals and health systems, so the goal of healthcare reform is not just about insurance exchanges or the absolute economics of an individual provider. It really is about lowering the cost of care and improving the value of the care that people receive. So what that looks like is addressing both of those, and from a value perspective, raising the quality of care. And this really is not entirely a new program associated with healthcare reform. It's been an evolutionary process to the current state that we see now with the Affordable Care Act. Back in 2006, this hospital at least began a robust quality improvement program where we began measuring very specific quality indicators. Those began with a small number, reported to the federal government, and the initial beginning of this was pay for participation. They would pay us more for participating by submitting these quality indicators. Then move toward pay for performance, where you now have the government with all the indicators in their database and can compare hospitals one to the other, which has set the stage for the Affordable Care Act to introduce things such as value-based purchasing, where the government says, I want to move from being a payer of volume or for services or things you do to patients to a payer of the value of care you provide over the long term of that patient. Value-based purchasing takes those indicators that we measure, very discrete indicators. We measure hospital-acquired infections, we measure pressure ulcers, and a host of indicators that we submit to the government, and it takes those indicators plus patient experience. And so there is a patient experience measurement program called HCAHPS, universally applied across all hospitals around the nation. And those hospitals report those measurements, and then we are compared one against the other. And on the basis of those comparisons, reimbursement is now connected, not just to what you did for a patient, but how you rank against other hospitals providing those services across the entire nation. That is a really big change to hospitals that is embedded within the Healthcare Act itself. What it looks like for us as a tertiary center, for instance, we receive some of the sickest patients that there are. And you may have a small hospital that moves that patient from a region into the tertiary center when they're much sicker. But we are, in fact, accountable equally for those same indicators, regardless of the acuity of those patients, and paid as a result of that. The model itself holds back reimbursement for hospitals. So 1% this year is withheld. And the way we get that back or qualify for incentives in the value-based program is how we rank compared to all other hospitals. And those in the top percentage of those receive incentives. We're fortunate here. We are fortunate to look back over time and see that we're no longer just one hospital, because we would have a difficult time if that were the case. But being a system of care where there are multiple hospitals and providers and partners working together, like the School of Medicine working with us, we have a robust infrastructure to maintain that level of care across an entire region. We're also fortunate to have started this process a long time ago and positioned ourselves well. So this hospital ranks #1 in patient satisfaction across the entire nation for the inpatient care we provide. And so it positions us to receive incentives in the program. In addition to that, we have seen our relative performance on all the quality indicators go up. And I say all that to simply say, as members of the community and as business leaders in the community, we all understand how important our medical school and our hospital system is to the economy of Eastern North Carolina, and certainly that locally. And I want you to know that we are, in fact, making progress and achieving goals associated with that healthcare reform. Value-based purchasing is one component of that. Readmission penalties are part of the program, so hospitals have to find ways to reduce readmissions to hospitals within 30 days, or there are penalties associated with that. There are also penalties associated with certain conditions that happen in a hospital. We call them events of harm, but they could be certain types of hospital infections, as an example. When you look at a patient that has heart surgery, if they were to receive immediate sternal incision that became infected, that patient with mediastinitis we can't be reimbursed for their care, both for the original operation that they had and subsequent care to repair that problem. So there are new penalties associated with the program as well that are built to drive quality and value.
I think for the Hospital Association and for the state and for the country, what is most important to us about healthcare reform, and quite frankly the biggest opportunity, are these types of meetings and these types of discussions. What we've absolutely seen in the last 3 to 5 years is a willingness to have frank conversations about what our healthcare system looks like. I don't think anybody up here can say that we have all the answers. And as much as I would like to say that Steve and Dr. Cunningham have all the answers, I don't know that they do either. And so this has to be a broad-based, collective effort to move this system forward. We're talking about 1/5 of our entire economy changing in a matter of 5 years. That's a heavy lift. And the more I travel around the state, the more these types of meetings are happening, and the more I see that they're absolutely critical. Because working with the business community is absolutely what we need to do to make sure that our health systems are performing the way you need them to. I think another big thing that you guys will notice, if you haven't already, is something that Brian touched on, which is systemization of our entire healthcare economy. I live in Durham, and I don't think I could find an independent physician. And the reason that's happening is because the federal government has sort of said hospitals need to be in charge of a wide continuum of care. And we think that's a good thing. We think that coordination is a good thing. We think that communication across settings is a great thing. We have to communicate and be efficient and provide a continuity of care that we've never been able to do before. Technology allows us to do that. This is happening all over the country, where you have systems working together. And in eastern North Carolina, the great thing is that we have a Vidant that can help support an entire robust system, even in the most rural of counties. You've got a world-class health system right there. So I think for you guys, that's a significant change, and we think it's a good thing.
Brian, welcome.
Thank you.
Our question right now for the panel, if you'd like to respond, is what implications will the law, the Patient Protection and Affordable Care Act, have for healthcare providers such as hospitals and doctors?
Sure, thank you, and my deepest apologies for running late today. I do appreciate the opportunity to be in attendance and speak with you about this very important issue. Impact on healthcare providers, there's a few things, and I'm not sure if they introduced me, but I'm with the Civitas Institute, so this is from a bit more of a policy analyst perspective here. But certainly some of the impacts on healthcare providers, there's a few I wanted to touch on real quickly. First off is compliance costs. I've talked to a number of physicians, practicing doctors that talk about the burden of compliance costs, bringing things into the standards that are required by the Obamacare law, mandatory IT updates, paperwork requirements, and that's going to hit especially smaller practices particularly hard. A random example of that is my wife went to see an eye doctor recently, and there was all this paperwork that they were having to fill out, and the doctor was actually referring to them as her Obamacare papers. So compliance costs are certainly going to be something that can impact healthcare providers. Secondly, when we look at the Medicare system, one of the things that the Obamacare law, their attempts to rein in costs, so to speak, is to lower or otherwise freeze Medicare reimbursements to providers. So obviously what the effect of that's going to be is it's going to prompt fewer providers to accept Medicare patients because of that lower reimbursement rate, certainly as it relates to, say, private insurance patients. And of course, so that's going to make more Medicare patients chasing fewer doctors that will see them. So that's going to have an impact on providers and how they need to prioritize who they're going to see. And also, and it may have been touched on before I came in, but my understanding is there's some provisions that are going to provide, or intended to provide incentives or greater, patients greater access to preventative procedures, and of course that's going to influence patients' behavior as well as, to seek more preventative measures, and of course that's in turn could certainly influence or impact providers to alter the focus and the scope of the care services that they provide in response to that. So those are just a few things that I think jump out at me.
Right. Our next question concerns current health care plans and policies. Can you give us some explanation about how current existing health care plans will be affected by the law, those already in place? Go ahead, Brian.
Okay, I'll keep going, I guess. Current health care plans. It's interesting, the CBO Congressional Budget Office just came out with a revised projections saying that 7 million people will be pushed out of their employer-provided health insurance. That's twice the previous estimate. That's largely, they're attributing that to the lower extension, of the lower tax rates on most workers. With the lower tax rates being extended now, there's less incentive to provide those tax incentivized insurance benefits. So most of those people, those 7 million people, a lot of those are going to be put onto the exchange, the insurance exchange programs, and picked from the the government-approved plans set up by the exchange. And one thing too that I think is important is any folks that have the high deductible health savings account kind of insurance coverage, and I have that for my children. The mandates in the Obamacare legislation are going to effectively eliminate most of those HSA style plans. which currently more than 11 million people have. And that's largely attributable due to the medical loss ratio requirements in the law that requires insurance plans to spend 80% of their premiums on medical claims. But, really the whole point of a high deductible HSA plan is for people to pay lower premiums, set aside extra money in these HSA, these health savings accounts, and pay for more of their medical care out of pocket. So effectively, a lot of these, or at least most of these HSA high deductible type plans are probably going to be wiped out because they're not going to be able to fulfill those requirements.
Yeah, I think what they call it is grandfathered plans. So if your plan is in place now, there are a few new requirements that you'll have to meet due to Obamacare. You'll have to, if you provide coverage for dependents, you'll have to extend that coverage up to 26 for age 26 for children. You have to eliminate annual limits on coverage, and provide at no cost preventative care. A lot of the other provisions in Obamacare you'll be free from if you maintain your grandfathered plan. How the health marketplace and the insurance exchange really will affect your financial decisions, I think will be interesting to see. And this is a great conversation to have because it turns out we have a lot in common when it comes to what the issues we're facing are. Administrative complexity is absolutely a major issue. To move, like Brian spoke to before, what we call moving from volume to value, takes a lot of measurement, takes a lot of systems in place to be able to measure what the value of your healthcare is, what is the quality, how do you gauge who's successful and who's not, how do you know exactly what hospital is outperforming another. And those systems are very costly and very intricate, and that's another reason that you see new arrangements and new business arrangements, new partnership arrangements, because there's a sense out there in the healthcare field that we need to shoulder this cost and move to a value-based system as a field. And so you're going to see a lot of different ways of partnering across the state, and frankly, you see that across the country.
I think they've covered the insurance component of that. I'll only add that the complexity of our regulation can be, in fact, an impediment to us being able to be compliant. And we certainly do favor a simpler process to be able to construct these entities in the future. But shifting toward preventative care, making sure that we provide greater access is a key goal, not just of this health system, but all health systems around the country now. Knowing that we have to live in two worlds while we are reimbursed in one that takes care of sick people and building one that will prevent the diseases that we aspire to cure in these hospitals today is certainly the complexity with which we're approaching healthcare reform. And insurance companies making that available does more than just provide insurance coverage and care for people. It brings more people to the table as consumers. And so we are truly living in a world where our mandates are to continue to provide the access. And as this hospital, that's our promise and what will continue to happen. But simplifying the law, simplifying the regulations is also a new part of policy that we have to embark upon.
All right, thanks. Our next question is question number 6. Perhaps it should be the $64,000 question, or the multi-trillion-dollar question. And understanding that you can't predict with absolute certainty what the future holds, I would like your thoughts on what impact the law will have on overall health care costs in the country. Obviously, the goal is to reduce those costs, but what do you see in the future for health care costs?
From my opinion, from my viewpoint, quite frankly, I see this just exacerbating the increase of healthcare costs in this country. And what you need to do is you need to step back and look at what's driving the cost under the current system, or the previous system, I guess we can call it. What was driving the cost up under that? And a large reason for that, I would certainly argue, is the third-party payer system that we have in this country. Patients themselves just pay about 12% directly of their medical care bills. The rest is paid either through their insurance or through government programs. Specifically, more than half of our medical care bills are paid through the Medicaid Medicare systems. And that was according to a report released by Medicare researchers last year. So obviously when someone else is paying the bill, it increases our demand. Your demand for something, if you're not directly paying for it, you're going to consume more. That drives up demand. On the flip side, the supply side, supply is limited by a number of restrictions that the government imposes on the healthcare industry, and that's something, probably a discussion for another day. But getting to the fine point here, when you start inflating demand to such an extent while restricting supply, I mean, we all know Econ 101, supply and demand curve. What that's going to do, that's going to skyrocket the cost of something. And Obamacare, at least my understanding, is only going to shift more payment of medical care onto third party and insulate people even more from their costs of their health care, which is going to exacerbate that inflated demand. And so the inevitable result, in my opinion, is it's only going to force costs up. And when you look at the legislation, when you look at certainly some of the components of the legislation, it seems like they knew that was going to be the result themselves. I mean, why else would they offer tax credits to certain small businesses and subsidies on these health insurance exchanges? They offer subsidies for people earning up to $80,000 or more a year to subsidize to help them pay for health insurance. I mean, why would they offer these kind of subsidies and tax breaks if they thought it was going to become less expensive? So I think that's just kind of interesting how it's cooked into the legislation itself, kind of admitting, in my opinion, what the inevitable result is going to be of this. And, well, that's about all I have on that one for now.
This is the key question, right? This is what we're all concerned with. It's great that Mr. Lawler is here in the room. He has agreed to chair a new center we're calling the Center for Affordable Healthcare. And the reason is that we recognize as a field that making our health systems, making access more affordable, more efficient is critical to our economy, critical to our citizens. 5 or 6 years ago, maybe 7, we started the North Carolina Quality Center, whose goal was to hone in our hospital leaders on improving hospital safety, patient quality, and being transparent about it. And I think right now the next step to that is making sure that our systems are affordable for everyone to access. The work that Brian's doing, the work that Steve's doing, the work that we're all doing, it's incumbent upon all of us. This is a difficult lift. These conversations, I'll say it again, are very important. I think the question, is it going to drive costs down? I think, yeah, eventually it will, because we're going to see efficiency. We're going to see better systems, more continuity. In the short run, I think it absolutely will drive up costs. And why will that happen? Because you're going to see people come into the health insurance market, and you're going to see them starting to receive preventative care, primary care, more appropriate care in the right setting. Long term, the hope is really that as a field we can work together and work with the business community to create systems that work for everybody. I was in Burke County doing something very similar to this a couple weeks ago, and what I learned is that some of our hospitals and local health systems are contracting directly with small employers, large employers, creating their own systems within their communities, really because they saw a need. The business community came to them and said, we need something different. The insurance market isn't what we want. This is what our employees need. And they sat down at the table and figured out what would work. That's the hope, is that those systems will spread across the country, and we will see the overall percentage of GDP drop.
Thank you for the question. It obviously, I wish I knew the answer. I will say this, there's $1 billion cost over 10 years associated with implementation of healthcare reform by some estimates. And all this does depend on where you go to get the answer. If you go to proponents of healthcare reform in its current view, then you get a favorable opinion about what the cost structure will look like over time. No one doubts that it, in the short term, is much more expensive. But over time, are the realized gains. And the reason it's so complex is that healthcare is a dynamic thing. It's not like making widgets or something that you can definitively do and see the result of labor. In this case, I'll go back to 2001, and at the time when there was a tremendous surge of cardiovascular procedures across the country. When Medicare Part D came out and prescription coverage for preventative care was placed, we saw the nation go from 3% compliance with preventative care for cardiovascular disease to, with the use of statins and those sorts of drugs, 30% compliance, and then 60% compliance shortly thereafter. So we know a couple of things about our industry and how it responds to these interventions. One of which is when you make coverage available, people receive more care, whether that's through preventative care or whether that's through hospital utilization. Utilization goes up when more people have access to it. The counter to that, though, is can you prevent these diseases versus rescuing patients from them? That same analogy, with that increase in preventative care, we saw the progression of disease in the nation slow, and the utilization of high-end procedures actually go down remarkably, most of which we attribute to the technology innovation and the fact that people were receiving this care earlier and preventing the disease progression at the rate. So we saw 50-year-old patients that, Dr. Benson, you worked in the emergency department for years, and you saw 50-year-old patients with heart attacks, and now they are 70 years old. And the question, though, becomes, do we still provide the care to a 70-year-old as we did to a 50-year-old? And now we have baby boomers and more people with access to care living longer through preventative models that many people believe they still come back into the system just at a later state and perhaps more acutely ill. And if that is the case, then there is an unintended consequence of providing more preventative care that, while it is absolutely the right thing to do, and it is absolutely what we must do, the unintended consequence is we cannot be for sure whether or not the total costs of care diminish and by how much into the future.
We only have a few minutes left. I do want to provide an opportunity from members of the audience to submit a question. Is there anyone that has a question that they'd like to present? If not, I'll just move to our last question then that I have for the panel. What kinds of approaches are healthcare providers implementing in anticipation of the millions of uninsured that will enter the market in 2014 under the individual mandate? Obviously, a number of people without insurance now presumably will have it, and that will obviously cause a number of people to begin seeking care. And how do you see that affecting healthcare providers, and what can healthcare providers do to prepare for it?
Obviously, in terms of what they can do or what they're doing to prepare, I'll let the other panelists, they'll have a lot more insight on that than I do. But one thing we do want to emphasize, and I touched on it earlier, is, quite frankly, they need to be bracing themselves for an influx of demand for their services with fewer doctors available to treat patients. As you mentioned, we're going to have millions of more people under insurance entering the market willing to consume medical care because a third party is paying the bill once again. And we can look at here specifically in North Carolina that one of the big issues is the Medicaid expansion. And Medicaid expansion, that could put as many as 500,000 more people into our Medicaid program here in North Carolina. And that's a program that already saw a 50% increase in its enrollment in about the last decade, and we're talking about adding 500,000 people onto that program. Of course, the state legislature is taking steps to block that, but just kind of think about that. And also, as I mentioned, over the last decade, as the enrollment was increasing by about 50%, the number of doctors willing to see Medicaid patients has declined. So we see a huge influx of patients chasing fewer and fewer doctors. That doesn't add up to access to care. By my math, it adds up to access to a waiting room. And in fact, a recent survey, this is interesting too, a recent survey found that 43% of doctors are planning on moving up their retirement in the next 5 years. So that's only going to worsen this doctor shortage. So we're going to have, again, we talk about the climbing demand for healthcare services and medical care services, but the resources, I feel, may not really be sufficient to support that kind of influx. And I would be interested to hear what the other panelists have to say about how they're preparing for that.
It's absolutely going to be a challenge. I would agree with you. What I see happening across the state and across the country is a huge number of conversations around creating new pathways for patients and devising new ways to care for entire populations. At the Hospital Association, we work very closely with our public health department, working on prevention. We work with the Medical Society and their staff on ensuring that we have the right number and mix of physicians in our state. You see a lot of our health systems working with our academic centers, making sure that we're training the physicians that we need that meet the demand. ECU does a fantastic job, and Dr. Cunningham could speak about that, but does a fantastic job of training primary care physicians that want to stay in North Carolina, and that's what we need. But what they're also doing is seeking out new types of roles and new roles for nurse practitioners and physician assistants and even lay people. We see one major health system looking to the faith-based groups to really drive congregation-wide healthcare initiatives, prevention. So this is going to have to be a societal lift. This is going to have to be everyone around the table saying, what can I do to figure this out? This is the future of, again, 20%, almost 20%, 17, 18% of our GDP. So it's going to involve everybody sitting around the table working out these issues. And it's exciting to be a part of it, frankly. It's really difficult, it's really complicated, but it's exciting because you get to do things like this and you get to have conversations about totally new ways of thinking and delivering health care, which is happening all over the state. We have community care in North Carolina, which many of you may have heard about, which is a nationwide leader in primary care medical homes. This idea of team-based care, high touch, low cost, using whatever resources a physician office has at its disposal to touch those patients and improve health outcomes and health status. That's the key, right? Prevention. So I'll let Brian get into some specifics.
Thank you, Chris. Obviously there is a lot to strategy here as it relates to the partnerships required for us to be successful in the future. And Chris, I agree with you entirely that you sort of look at our position and it's enviable to many places around the country. And the reason is because we have, over time, particularly in the last 2 decades, built a system of care that can accommodate many of the challenges that lie ahead for us. 30% of the expenditures that we talk about from the nation's perspective, 30% of those expenditures are in hospitals, but only 30% of them are in hospitals. The other, when it relates to healthcare, the other expenditures, 19% are physician practice-based expenditures for professional services. 10% is pharma. So there's a host of other cost structures involved in this when you're talking about reducing the cost of care. But the single largest component that we can look to the easiest is the hospital care. It's the most expensive component of the care continuum. So working backward from a strategy perspective, we've said today that the thing we have to do well is to provide best experience for patients. Not just because it's the right thing to do, but also because it's the competitive position that we have to have. We're being compared to all other hospitals. We have to provide better access. And when you think of partnerships, as an example, the Brody School of Medicine is one of the nation's premier providers of primary care medical physicians. And to Chris's point about their success in that, it's a huge mission of the School of Medicine for which they do a fantastic job. And I think The last numbers I saw were 30% or so of the physicians you graduate stay in Eastern North Carolina. 50% stay in North Carolina. Well, that's a huge benefit. In addition to that, there are all these hospitals now that are part of a health system. And you'll see that trend growing. Consolidation is the way markets adjust to increasing cost pressure. Spreading the costs over larger numbers and larger components of a book of business is simply what all industries do, whether they're the car industry or whether they are healthcare industries. So consolidating the structure for the cost management side is an important part of that. Linking together to create these pathways that you heard about for care. And the goal of that is to give a patient all the care they need and none of the care they do not need, and in the lowest cost setting that we can provide. To do that, we have to have more regional access points for patients, whether they're nurse practitioners, nurses, or physicians. And so from a health system strategy perspective, we are growing a physician enterprise within the health system. There are now close to 300 physicians in our own provider base. We are partnering with the university because they provide this a tremendous resource to make sure that we have providers for the future. And internally, managing our system as if it were an entire system of care. I think that the terms I've heard are, we are a 1,500-bed hospital now across Eastern North Carolina, not just a 900 one here and a loose confederation of smaller hospitals around. One system of care to make sure we are driving care to the lowest cost setting possible. And without going through the details, there are care maps that help us achieve that. So there are the kind of strategies that we are employing as a health system. Creating the electronic health system is another key component of this we haven't talked a lot about today, but there are meaningful use mandates in the Healthcare Affordability Act as well. And what they do is just help us provide one record for patients. And we envision one community health record, that patients, regardless of where they are, providers or hospitals have access to the record that follows you through your continuum of care for a lifetime. And one of the other unique possibilities here in Eastern North Carolina is there's not a lot of out-migration of the population, and because of our history, not having a dense population in any one place, there's not competition that is heavy pulling at the patients as consumers. That gives us an opportunity to build a real network, a real fabric of care across Eastern North Carolina through which we can measure outcomes, improve those outcomes, and make sure we provide that care at the lowest cost setting. We can measure all that here in a way that many places can't, and continue to evolve our system of care accordingly.
Thank you. We're about at time, but I do want to give each of you just a few seconds, if you can, keep it to a minute or less, on any concluding comments that you have. This is not obligatory, but if you have any concluding comments, we'd love to hear from you.
Sure, I'll just close. Again, this is from a policy analyst perspective, a policy advocacy organization that I'm representing. Basically, when you look at the bill, when you look at the Patient Protection and Affordable Care Act, also known as Obamacare, it offers patients little protection, makes medical care less affordable, and makes care less accessible overall. The cost of medical care is so expensive, largely due to third-party payment for medical services. Obamacare only worsens that problem. Health insurance, in turn, is so expensive in large part because of the high price of medical care, and also due to heavy government restrictions on the insurance market. Obamacare only worsens these problems. More specifically, Obamacare imposes costly mandates and compliance costs on businesses. There are countless new taxes included in Obamacare that we didn't even have time to cover here today, unless you guys covered it before I came, which I don't think. I'm not sure if you did or not, but obviously those taxes are going to hurt the businesses and the economy in general, which can prompts the health insurance or healthcare industry to consume a greater share of our economy. And of course, the great uncertainty about this wildly complicated and still not completely understood legislation helps to depress business investment and slow our hopes for economic recovery.
I think that if anything, the Patient Protection and Affordable Care Act has done one good thing, I can say for sure, and that's forced us all to have this conversation. It's forced us all to take a look at how we care for each other, how we care for our communities, and how we care for our entire state. I don't know, and I don't think anybody up here can say for certain if the ACA is the right law, if it's going to turn out to be cheaper, if we're going to be happy with it looking back in 50 years. I don't know. But what I would say to you and urge you all to do is continue to have these conversations and continue to be at the table and continue to think about how you can improve the health status of your community. There are a lot of small business owners here, and you know, it occurs to me that you guys by nature are eternal optimists. You wouldn't have gone into business for yourself if you didn't think you would succeed. And I imagine that if you could afford it, you would provide health coverage for your employees, that you want them to be healthy, you want them to be happy, they're a part of your family. And it's incumbent upon all of you and incumbent upon all of us up here to make sure that you can do that in an affordable way. Whether Obamacare is the answer, I can't say, but I can say that the answer is in this room for sure. And what the answer is, I don't know. But this is the right venue, I think.
Well, let me say thank you first for having us here today, and thank you to Chris and Brian for your insights as well. And on behalf of the health system, you know, it's a privilege to do what we do every day. And we are built really for this community. I mean, for us, that's why we're here. And so I think one of the first things to take away is these are really complex issues, and they're frightening issues depending on how you look at it. But you need to know that your health system is committed to its mission, and it will continue. And we will make sure we're successful in being able to continue to provide world-class care and even better care to Eastern North Carolina. We're going to leverage all advantages that exist here that we've spoken about today. Starting from where we are, we know we have an advantage as we look forward. But we are going to have a lot of help and a lot of support. This is going to be partnership, as we discussed earlier. This is not something that we can solve by ourselves. So this is really a community, a region issue, as Chris stated. But we're also here to be a resource, and so we want to be helpful to you as business owners as you're planning and preparing for the steps that you need to take to whether to deliver insurance coverage or help make sure that you're providing the appropriate preventative care. That's part of our mission as well, to be an educational resource as well as a healthcare provider for you. So we're here as well to help you in that, and are more than happy to do so.
Thank you. Brian Balfour, Chris Koronic, and Brian Floyd, thank you so much for being here.